Let's introduce your case and your team.
Yes, just go to PPT, please. Okay, so with me is Dr. Sri Krishna and Dr. Daya Vaswani, and Dr. Nihant on this case today. So my patient is a 74-year-old male who had an unstable angina. I think it's non-QMI. So during which time, both LCX and RCA lesions were identified, and LCX was around 80-90% lesion, and that was treated, and RCA was CTO then. So, and that's the reason patient is here today. And ECG, there was changes, and echo, there is RWM in inferior territory, and those are the risk scores. Next slide. You can see this is an echo. So yeah, next. Yeah, this is the echo. You can see hypokinesia of inferior wall, still preserved myocardium. Next. And overall LV is kind of mild to moderate LV dysfunction. So next. Next slide, please. Yeah, this was the angiogram during the index procedure. You can see RCA is filling retrogradely. Next, click next. Yeah, so RCA is filling retrogradely, and LCX is showing tight lesion. And you can also see RCA filling from a lady. Play, please. Yeah. Yeah, you can see RCA is filling retrogradely. Next. Yeah, just play. Yeah. So you can see RCA is total occlusion. Also, origin is a bit abnormal, and it's kind of ambiguous cap here. Next. Yeah, so this LCX was done during index presentation. So next, click next. Yeah. So this is LCX result, which is pretty good. Go next. And this is, for today's analysis, you can see this is the proximal cap, which is quite ambiguous. We can see both in fluoro, and I gave even your CT images, which you can make out. There are two branches coming off the proximal cap, and there is one branch coming off, distal cap, which you can see there. And the CTO length is kind of 18 millimeters, and there is no calcium, in the CTO, which you can clearly notice. So next slide. Next slide, please. So this is, there is no angulation within the CTO segment. You can also notice that in CT. Next slide. And just press, let the image play. Click, please. Click. Press next. So press next. Yeah, play the video, please. So you can see origin of RCA is above the sinus. In CT also, you can see it is coming above the sinus. So that's the reason we were a bit skeptical about the support in this case. Anyway, we took AL. Next. So, and this is one thing which we did, it's a fluoroscopic view for proximal cap wiring. So if at all, IVOS-guided cap puncture doesn't work. So in this view, both branches are separated, and RCA is coming right in the middle. So we thought of using this view for proximal cap wiring. So we tried. We'll show you what happened. Next. Again, same thing, fluoroscopic view for proximal cap wiring. See, while rotating, you can identify the spot where, both branches are getting separated from your RCA axis. So that is what I'm doing. It was like RAO, kind of 50 to 60 RAO and around 20 cranial. So this is where both branches are clearly separated from the proximal cap. Next. But however, you won't get that 3D image of the location of the proximal cap. It's only based on this we can identify. So we have good interventional collaterals. Click. Next click. Yeah, that's one collateral which we spotted. Another click, please. This was another collateral, so which are quite good. Subtle collaterals. Next. And these are the J channel scores for both collaterals. One is 0, another is 1. And next. And this is the donor vessel. This is, we can even see the lumen areas in CT. We have a good lumen area at the lesion. So almost like 5 mm square. In CT, though it is not accurate, this became our habit to calculate, every time we do cases. Often, it coincides even with IVUS lumen areas. Next. So donor vessel disease is there, but not significant. So coming to the wiring strategy, obviously it is an ambiguous cap. And there are good interventional collaterals, and there is some support issues anticipated for RCA. My first choice was IVUS guided cap puncture, but if I look at both the branches are almost looking like nearly 70 to 90 degrees from the main RCA. That is one negative. So for IVUS guided cap puncture, because the visibility is not great. Next. So if that doesn't work out, I'll go retrograde and retrograde cap. So when I go retrograde, so this is one thing, there is a branch even at the distal cap, probably that can trouble. The only savior is entire CTO is non-calcified. I think that's the savior in this case. Next. Yeah, so this is the case, probably, Chet can discuss, and
Sharath,
I'll show what I've done.
Sharath, we'll pause you a bit. We'll have a discussion here on the stage and then...
Yes. Please go ahead.
Maybe for the discussion, show us the first simultaneous shot. Because sometimes
I'll show you,
the artery looks different from the single diagnostic shots.
Yes.
I hope you did one.
Yes. I strictly follow your guidelines, sir. This one, run thumbnail. Yeah. So, yes. So this is the dual injection. You can see in LAO, and as already CT showed us, CTO length is definitely not huge. But proximal cap is ambiguous, and this is the image, which in the view which CT gave. You can see, both the branches of at the proximal cap, going exactly in opposite way, RCA is in the middle. So these are the two dual injection views which we took. The second one, this one is based on the CT we decided.
And importantly, what you show here is simultaneous injection doesn't mean simultaneous injection, but waiting until the filling of the distal retrograde comes and then antegrade, because sometimes we see really...
The first picture of dual injection, you took the antegrade first and then you injected the retrograde. So can you show it again, Sharath? The first dual injection?
So, okay. Yeah, this is a dual injection.
Here you injected the antegrade first. We would like you to inject the retrograde first. Wait till the...
Antegrade I injected a little bit early, so actually retrograde only injected first. Antegrade, I injected a little early. The moment distal RCA was filled, I injected, but
it's good. It's a teaching point for, and also to wait. We see that it takes 3 seconds or 3 heartbeats to get to the distal. So always the large lumen injection into the donor vessel makes the CTO shorter. But you had a perfect workup of the case, and let's get some 2-3 opinions of how to approach. Antegrade first?
I think I was guided antegrade, but I think the side branches are not very optimal for the vessel I was guided.
I would suggest antegrade first and then go for it.
Yeah.
No.
I think it's always looking at the complications that are associated with retrograde. You can always fall back upon, but always can surf one, probably 5 minutes. If you can, it's a great success. Otherwise, you can fall back. I would have probably tried antegrade first.
So give me...
Usually do the retrograde first, and then the retrograde first.
You'll all up with contrast, please.
I think the first point that I would like to make is that very positive use of the CT angiogram to delineate the anatomy, identify the proximal cap, and identify a proper view for attempting the proximal cap antegradely. That was a great demonstration. The CT, IVUS was not antegrade first.
I agree too, because
right.
doing and preparing the antegrade is very important, even in a retrograde approach. So I would initially try antegrade with IVUS guide.
I would like to evaluate the proximal cap with an IVUS. It may not be successful, but at least I want to see the proximal cap with an intravascular image.
So you are already here in the retrograde mode.
Shall I show what I have done? Please, CO03.
I would a little bit disagree with your opinion then that this is not ideal for antegrade IVUS. Other than if it's retroflected, the IVUS will go. But you should not use a short tip
plain RL.
volcano. That is the biggest story. The short tip volcano is bad for side branches because it doesn't get in. So quickly review what you had done.
Yeah, just a small comment. As CT angio has given a lot of information, I feel in that, after CT angio, antegrade choice is the first choice, because now we know where the proximal cap lies. And after locating the cap proximal to the IVUS, then dual microcatheter will help, keeping one wire in the branch, second wire, that cap might help it.
Do you want to pass the collateral and tell us then the story why you are passing the collateral? Or
I'll tell the story first. Okay, so I tried getting into this branch. You can see RV branch because it is very tortuous. My wire was not going there. So with this a little bit of wire is in, I was not comfortable in taking IVUS down. I tried for a couple of minutes, but it didn't work out. So then I took my wire into, this branch, almost sinoatrial branch, you can see. And this branch is completely, it's a 90 degrees. I can show you IVUS. Can you please play IVUS, please, from this branch? You play IVUS. So this is the IVUS from this branch. We can notice, a good proximal cap, which is coming at 3 o'clock, but it is like very, brisk appearance. You can see, not that. It comes next. So, is it playing or not playing?
It is playing.
But you have micromillimeter pullback. 0.5 millimeter pullback per second or something.
Yeah.
So go fast. Little, you just, you can see here at 3 to 6 o'clock, you can see a vessel coming and, and joining. It's okay, but it's not like a gradual, and also you can see the branch which is coming and joining is also in the same direction. So that was the problem, I had. So what I did, I just thought of, wiring, with a microcatheter after removing IVUS. This is not live IVUS puncture, which I tried because even the branch is coming off the proximal cap in IVUS. I was a bit, not comfortable and not, great for IVUS guided cap puncture. So I thought of trying, just using my CT information. So I tried, wiring the middle zone. So, but the wire was just going into that branch. And as I already showed you in IVUS, both the proximal cap and the branch are sitting in the same angle, in IVUS.
But
so
you had a view.
5 minutes.
But you had a view where you told us that you can kind of And you could have used a dual lumen catheter in that position to puncture right in this direction.
Yeah, so to use dual lumen catheter, from this branch, the wire is not going distally. So wire is just struck at the bend in the vessel there. Yeah, I think that's a nice choice, but honestly, I didn't consider that option.
Okay, so you go to the retrograde. Now let's show the... he can, I think, quickly pass the collateral now, and then we go to the other lab. So you have a Corsair XS?
This is Turnpike LP.
Turnpike
Turnpike LP is placed into septal. So now I'm taking CO03 wire. So I'm going with CO03. So my reference is the same view, right? Yeah.
Yeah, the selective injection reveals that the vessel is often more tortuous than in the overview. So it's getting often more challenging. But Suo should take such turns. So comment what you do. With a heartbeat, advancing the wire on the reference and through.
Yeah.
Okay.
We crossed.
I think it's important not to push it, wait for the systolic, diastolic relaxation. And then, as far as possible.
Give me another wire connector, please. Sorry, another talker, please. Yeah. So we crossed with CO, so I think now you can see I'm at, you can see, this is the branch which I spoke about in CT. So, and the CO is just going into that branch. So let's go to LEO and confirm the course, please. Just go to LEO. Yeah, that's fine. Yeah, okay, can save. Yeah, come to RAO. Now I'll take my Turnpike LP to RCA, then I'll escalate my wire to Gaia 2. You can see, yeah, Turnpike went without much issue. So since the collateral size was quite good, so
it would be good to inject distal to see whether there might be a notch at the level of this side branch?
Okay, so once my Turnpike is there, I'll surely inject and show you. Yes, so I'm there.
Not
so
too far into the side branch.
Yeah. Wait, give me normal saline, please. Yeah. Keep Gaia 2 ready.
Any specific reason you're asking for a Gaia 2?
Even Gaia 1 can go. I have to escalate. So, because in CT, this lesion, appeared just a plaque. There is no calcium at all.
Exactly.
So there was only one spot of calcium that is again, distal to the distal plaque. This is fine. No.
I think it's important to see whether there is a notch where you can aim at, or whether you have to penetrate.
So you can see it's again, ambiguous distal cap.
So it's not trivial because here you can get out as well, and I think you need to puncture. And from retrograde, I would always prefer a Gaia third because you take away the power of the wire because of the long course of the microcatheter through the heart. So a Gaia 3 is, I think, more powerful. And here you see that there will be a problem because you have no marker of your proximal cap, actually.
Why? Two already open? Okay.
So yeah.
Since Gaia 2 is already opened, so I'll just check my luck here.
I think we stay a little bit with you for another 3-4 minutes, because that is an important step, and it's sometimes good to have a live step in a live transmission and not fluoro storage. As far as I know, my friend Cambis in Rome, they will have found anyway a very complex case which takes them long enough. So this is exactly what I had a presentation today about what is the problem of the switching from ante to retro. And he tried everything, Antegrade, but still the problem is that you have no wire marking the proximal cap, even if it would be subintimal. So now you have to blindly find a way at the distal ambiguous cap, because you have no target.
You can see, the wire is just jumping into side branch.
Yeah. So you need something stiff.
Yeah, so I'll just escalate it to Gaia 3, as you suggested. If it doesn't work, then I'll move on to Harnett.
What I would even suggest is
Gaia 3.
To leave the wire there and the collateral there, and now try with a stiff wire to puncture Antegrade, because if you don't mark the Antegrade cap, your retrograde wire could go into nowhere land.
Absolutely, because we are talking about an ambiguous retrograde cap now, so we need something to guide us. So Antegrade, even if we are going subintimal, we are okay. At least we'll have a track where to go.
Oh, okay. So I'll show you what we tried. I had suggested, I think. Or this is where we left you. So first I tried Gaia 2. It is going into RV branch. Then we tried the Gaia 3. So with Gaia 3 also I had same problem, and this is Harnett 14. So Harnett 14 a little bit penetrated, in the direction of distal cap. So then immediately I thought, I don't want to go with this wire. So whatever penetration or channel I created, I wanted to track with Gaia 3. So now I took Gaia 3. I'm just trying to track into that channel. So or that opening I created in distal plot. So I'm just checking my luck. Yeah, this. Otherwise, I'll upgrade again to.
I would
maybe IJCTO.
If you don't progress, I would really go back to the Antegrade part with a side lumen catheter and puncture with a Conquest or a Hornet that you have towards the distal wire. Because the proximal cap preparation is essential for a successful CTO like this.
Sharath, we feel that the puncture between the anterior cap versus the distal cap here, both are ambiguous.
Yes.
In the anterior cap, at least you have more control on it. While the retrograde cap, you do not have any control on it. I mean, we don't know where you're going to puncture. So what we strongly believe that leaving this wire here in the retrograde position, the antegrade puncture would be safer and more predictable.
Yes, yes. I take your point. So
Sharath,
that's,
in the initial CTO, you have shown 2 branches coming out in the antegrade
yes.
part. Then you keep 2 wires there, exactly in the middle, in the same angle. If you puncture antegrade, will it give a benefit?
Yeah, I mean, that essentially, only guides in terms of course, but uh, not exactly in, the cap. So, yeah, we are only making sure that, our course is correct. Just give me that IJCTO wire. Yeah, right.
You even want to go to CP20?
Yeah, CP20.
It's called Astato outside of Japan, but in Japan it's Conquest Pro 820. It's the same wire, essentially.
Sharath, for the sake of the audience, can you tell us when you're puncturing the distal cap retrogradely, what are the precautions you're taking, and what is it that is giving you confidence that this is the place where you need to puncture? I mean, are there any predictors or are there any guide for you to where exactly to puncture?
It's an ambiguous distal cap. So, I mean, I don't have any guide, but in CT, I basically noticed this is the view, where your distal cap is separating well from the side branch, and I'm just puncturing in that. It's a blind fashion, so I think there is nothing, which is guiding me here. But what is most important is I keep a track on, PVCs on the system. So if any PVC is coming, that means I am not in right place.
That is a little bit tricky because the right ventricle doesn't cause too much, or the part where you are doesn't necessarily cause PVCs. The patient may feel pain that is often more indicative of.
You can see, there are a lot of PVCs.
Okay. But you made some progress, but maybe in the other plane, be confirming the position with such a stiff wire.
Record this, go to LEO. Yeah, it looks in the direction of RCA. Yeah, you can record this, and exactly towards the other side of RV branch origin. Come to same RAO view, please.
Since you have already punctured, or we presume that you have punctured the distal cap, would you downsize your?
Yes, I'll do that. I just want to get little up because otherwise, these otherwise won't give you great support.
So how is the feel on the tip of the wire?
I have resistance, definitely.
Okay.
Looking at the CT scan with almost zero calcification there, if you're in the true lumen, I won't be getting so much of resistance nor the ventricular beats.
So what are you doing? You are advancing your microcatheter now?
No, I'm only trying to send my wire. Now I'll take my microcatheter support. I'm pushing microcatheter as close as possible just to garner some support.
I think your tip of the wire and the microcatheter length is too long. In that case, the force doesn't go into the tip of the wire, so it's very nice to put the microcatheter in. So you have to make the tip of the wire and the microcatheter relatively smaller distance to make the wire go penetration easier.
Hi Sharath, Dr. Girish here. If you think the resistance is more, would you go to a hydrophilic wire within the body to traverse a certain distance? Like a pilot 200 or something, would you like to try?
And in such scenarios, pilot really won't give you a good support to get into cap. So once I make a way into the cap, then, I can de-escalate my wire to either Gaia or pilot or whatever.
So now your
I have to
microcatheter is...
essentially,
Yeah.
I have to essentially make a hole in the distal cap. So without that, these wires may not work.
I
So
think
microcatheter is back again. What are you doing?
Yeah.
What is your plan to understand the angio?
I'm only just trying to penetrate cap and go a little bit into CTO segment. Then I'll de-escalate Y to Gaia 3.
But I thought you had already penetrated.
Hi.
Yes.
Okay, Dr. Sharath,
okay, I'll take
I'm
Gaia 3
Hamanaka,
now.
and I'm agree that
Give me Gaia 3
try
now.
the Antegrade approach from now.
Yes.
But if you
I'll just
want
try
to,
with Gaia.
yeah,
I'll de-escalate wire and try with Gaia 3. If it doesn't move, then I'm going to start my Antegrade again.
Yeah, if you want to strengthen the retrograde puncture strength, so it is one idea that using the double lumen catheter through the retrograde approach.
We don't have that Sasuke with us.
So
we can start workhorse wire and then take Sasuke and then we can puncture. So I don't have Sasuke in my lab.
We go to the other lab. While you proceed, we watch you on the second screen because there is some progress in the with the gladiators. Or is there? Yes. The image doesn't look like progress, but maybe that's not. No?
No progress.
So please prepare Antegrade.
Yes, yes.
I have been in these situations many, many, many times, and I know...
Yeah, I came back to Antegrade.
Take a dual lumen catheter, take a stiff wire.
Yeah, this is a dual lumen catheter into synodal branch. Then I tried Gaia 3. And
Is it
also
live
Conquest.
now? Is it live or is recorded?
No, it's just recorded.
Okay.
This is recorded.
So you did not get yet
yes. So
access.
now my plan is I'm moving to my next step. So what I'm doing, so I decided to knuckle Antegrade. So with the balloon trapping of microcatheter. So give me 3mm balloon, please. 3.58.
So power knuckle.
Yes.
But for the power knuckle, you actually need to kind of pinch the proximal cap that it works.
It's almost like we are going around the proximal cap now.
Okay.
So my microcatheter is in this is the reroute microcatheter. So, holding.
Sharath, can you show the actual live one? This is the recording one.
Yes, sir. Yeah. This is live. Give me again the wire. Renato wire, little bit table up, please. Table up.
Is this always the projection that your CT tells you?
Yes, this is a projection.
I think that for proximal, always a little bit of cranial angulation would be helpful.
Yeah. So Anyway, while doing knuckle, I'll come to my LAO view. Please give me the Renato wire.
No, I mean an REO AP, REO cranial for this osteal less foreshortening.
So what I'm trying to do, I'm just trying to take microcatheter parallel to, yes. So the balloon, go to LO, please. Please connect balloon, please. Don't pull anything.
For the sake of the audience, Sharath, can you just explain how exactly are you knuckling?
Yes, see, there is a balloon, 3 millimeter balloon here. So, and there is a microcatheter parallel to the balloon. So what I'm doing, I'm just, wait, you're connected? Yeah.
What kind of microcatheter?
Let me bring my microcatheter back. Yeah.
What kind of microcatheter do you have?
Yeah, this is reroute. It is, it's something equivalent to fine cross. Can you dial it?
But I think that's a problem because when you squeeze this microcatheter, usually you do that with a Corsair because the Corsair retains the space, yeah? And that you can really...
Give me gladius.
Knuckle, still have the lumen. Well, when you take the fine cross, you squeeze the lumen.
Yeah, Sharath. Sudhir here, Sudhir Rathore.
Yeah, sir.
So, yeah, I know. So, obviously, in your case, the proximal cap is non-penetrable. So, there are two options you are trying to do. One is you take a stiff wire, CP12 or something, and go in the direction of proximal cap, enter a couple of millimeters, advance your micro, and then take a soft wire and knuckle. Or you are trying to do a base, which you have to dilate with a bigger balloon and create a dissection just proximal to the proximal cap. And then into the dissection, you put a soft wire and make a knuckle. So those are the two options. And as Gerard said, I think it's better to use like a little bit stiffer microcatheter so that it doesn't collapse with your balloon. Otherwise, if the proximal cap is not punctured, the wire may not go through the direction.
The wire is through somewhere?
What about sideways in this? Because in ultrasound,
go
they are
to that
parallel to
RF
each other.
cranial.
So if he dilates the branch and then tries to enter, because on an intravascular ultrasound...
No, the ultrasound went. He managed to do ultrasound in the beginning, but he had the feeling that it was not
cranial view,
information. So your wire advanced.
No, but that is just going into
the other branch,
the side branch.
Okay.
So just go to LAO, right?
Hi,
so what I'll do is I'll just take a balloon little back or microcatheter little up,
Sharath,
down.
we have Dr. Yamane to comment.
Yeah, actually, as Sadia mentioned, that the base technique is very nice. What I mean by that is probably 1.5 millimeter balloon for the side branch inflation, and halfway in the side branch and halfway in the supposedly proximal cap. And then you can advance polymer jacket wire, inflating the balloon, because that prevents the migration of the knuckle wire into the side branch.
But he has two side branches.
Yeah, that's a problem.
Yeah, but still, you can push a little bit and then confirm the two different projections, because otherwise the stiff wire has a risk of perf. So if the wire perf is a little bit troublesome, we have to stop including.
Little bit.
Yeah.
Can we take two balloons and side branches and try? Why don't we try two side branches balloon and then try? Now there is no other options left out, so minimal options left, Sharath.
Yes, sir. Yes, sir. See, otherwise, simple-looking CTO, except for ambiguous proximal and distal caps. And
But I think
with impenetrable caps.
But you need this other projection. I think in this projection, you cannot discriminate your wire, your branches for the puncture.
Okay. This wire, because of the balloon, it is not forming knuckle there. So I'll just give a frank knuckle here.
Which wire is that, Sharath?
Yeah, this is Gladius MG.
I may think, I think that this wire as a first wire will not puncture because your previous wires didn't puncture either. So you need really something stiff for the initial cap penetration.
Sharath, what we are saying is, without making any puncture in the proximal cap, can you do a knuckle like this? At least enter the CTO body and then knuckle, right?
Yeah, see, there are two ways. Yeah, one is, what Dr. Emanet talked about. The other is, just balloon trapping microcatheter and, knuckling. So, but that's another way, so which I use. Yes, but here, the overall space, available in proximal RCA is very less for me to handle. Yeah, that's a thing. And when I did a bigger knuckle, so it is not forming because the balloon is already, inflated there. So yeah, that's okay. Let's now just go to the view, arrowcranial view.
Another option is you can knuckle from the retrograde.
Yes, yes. So since RV branch is really big, retrograde. See, otherwise I would have preferred retrograde knuckling. As a branch is quite big, I'm even knuckle also gets into that branch repeatedly. So that's a problem with retrograde.
Had the hornet which moved ahead of that retrograde branch, taking the distal microcatheter ahead of the branch, maybe you can knuckle.
Oh, okay.
So the gladius will not penetrate. The gladius is a 14,000 wire. You need a Gaia 3 or a Conquest Pro. You have an Astato on the table. Use one of these knives.
I tried antegradely with all these wires, as I already showed. The problem is, they're just skipping into the side branch. And
it's a matter of the tip shape.
Yeah.
Yeah, Sharath, you deflate the balloon and use a little bit bigger balloon. Like, what size balloon is this?
This is 3.5.
Yeah, use 4O balloon in the proximal vessel, not in the cap, just where you think the cap is. And the idea is to create a dissection in the proximal vessel and then remove this balloon. Because this balloon is not helping unless you enter the proximal cap. It's not providing enough support. It will provide support once you, and then you try, like why you call it scratch and go. So you go in the proximal vessel in the dissection and catch, and then you can go the knuckle, yeah.
I'll just show you, I knuckled Antegrade, so I can show a couple of things. You can see this knuckle, but it is going into side branches as predicted. So now what I'm doing, again, I'll just take my chance or luck on retrograde knuckle. So knuckle is just going into side branches, despite
the case. I'll show the first. This was a dual angiography, so with which we started. We had an ambiguous proximal cap, ambiguous distal cap. That was the issue. And both caps were very hard. No wire was perforating. we went Antegrade, tried IVUS guided puncture, didn't work out. No wire was getting into proximal cap. Went retrograde, but no wire was getting into distal cap. We tried Gaia 2, Gaia 3, then Hornet 14, and then IJCTO 20. So that was a situation, where we left. So what we did is, we did a base. You can see here, this is a 3.5 millimeter balloon with a corsair sitting on the side, through which I advanced a Gaia 3 wire. It's literally getting into subintimal space. So, and I confirmed that I'm in subintimal space. We can see here, the wire clearly looks, outside. Yeah. So you can see here. So the wire clearly looks outside the lumen here. So we confirmed that we are in subintimal space, and the wire went into CTO beyond the 2 branches, and we advanced corsair into CTO, and then I did a knuckle with the Gladys Mongo. This is a knuckle. So, and essentially it is just to loosen the caps and entire CTO segment. And once knuckle is down, and then I brought in, this is very important step. You have to keep your balloon inflated always, not to allow the subintimal space to expand. So while this thing is going on, the balloon is, we kept on inflating, deflating based on the movement of devices to not allow subintimal space to expand. And once the wire is in, then I took a trap liner in. So you can see trap liner is in. And we did a reverse cart. And clearly, antegrade is subintimal, retrograde is in true lumen. So we did a reverse cart within the CTO segment after crushing entire CTO, which was not penetrable before, and brought the wire into trap liner and then externalized. This is externalization, and followed by IVUS, and then we marked subintimal space and where it was true, where it is in false. As we deliberately entered into subintimal space, just 5 to 10 mm from ostium, so we had to stunt up to ostium, and this is the final result, which we have got in the patient. And you can see all the branches also intact.
Okay.